Good evening, one and all. On behalf of Dr. Agarwal Institute of Optometry, I extend a warm welcome to each and every one of you for the 30th episode of Optometry series. On behalf of my teammates, Ms. Anshika Shah and Ms. Meenakshi, I'd like to thank each and every one of you for your continuous support towards Optometry series. And I'm very glad to welcome our today's moderator, Mr. Premjit Bhakat, sir. Hi, sir. Thank you so much for joining with us today. Yes. So thank you for Anshika ma'am for bringing in Premjit sir today. So ma'am, so tell us what is the today's topic and why did you brought Premjit sir especially for this particular episode?
So thank you, Gomati. Today's topic is about contact lens, and when we hear about contact lens, we have very few people who are experts in contact lens, and one of them is Optom Premjit. So I very heartily welcome Optom Premjit to teach us and enlighten us about various fittings in contact lens. We've already heard about always types of contact lens, but when it comes to fit on eye assessment is what we are going to discuss today. So I think no one would have been better than Premjit to explain and help us out. So thank you so much for joining us, Premjit. Over to the MC.
Yes, I'm very happy to welcome today's MC, Ms. Atifa.
Good evening, one and all. I'm Atifa, studying first year bachelor's in optometry at Dr. Agarwal's Institute of Optometry, Chennai. I'm very happy to introduce today's moderator, Mr. Premjit Bhakat. Sir is presently working as assistant professor in optometry department at Manipal Academy of Higher Education, Karnataka. Sir has been teaching and practicing contact lenses for past 15 years. He completed his Master of Optometry with distinction from Bharati Vidyapeeth University, Pune. Sir is an active IACLE member and holds a FIACLE status since 2008. In 2015, he cleared the fellowship exam by the prestigious British Contact Lens Association and gained the FBCLA status. Sir enjoys teaching contact lens and UG and PG students and has vast experience of managing complex cases with advanced contact lenses. Thank you so much for joining with us today in your busy schedule, sir. The presenter for today is Ms. Deepika, studying second year Masters in Optometry at Dr. Agarwal Institute of Optometry. Ms. Deepika, please start your presentation.
Yes, Deepika, you can
Yes,
start the presentation.
I'm sharing my screen now.
Yeah. Good to go, Deepika.
Good afternoon to one and all. I'm Ms. Deepika, studying Master in Optometry, second year in Dr. Agarwal's Institute of Optometry. Today's topic is about contact lens and fit assessment. Introduction. Successful contact lens wearer has been defined as being able to comfortably wear one's contact lenses for at least 12 hours per day for last 6 days per week while still being able to see at least as well as while wearing spectacles. Contact lenses have been a number of benefits for both children and adults, which includes improving one's overall visual satisfaction, ability to play sports, and one's overall self-perceptions. Indication of contact lenses are optical, sports, therapeutic, corneal reshaping, prosthetic and cosmetic, ectic and corneal conditions. Contraindications, infections, seasonal allergies, hormonal imbalance and metabolic disorders, immune-compromised patients and unmotivated patients. The basic assessment starts from slit lamp examination of the anterior segment, measurement of ocular dimensions with the keratometry, dimensions and lid positions, which includes base curves, HVID, VID, and lid tonicity. Assessment of tears, non-invasive tear breakup time is seen, which is known as NABT, tear prism height, lipid layer evaluation, visual acuity, and spectacle refraction, and choice of lenses. First, it starts with the refraction, then keratometry, estimated the total astigmatism, which is total astigmatism can be calculated by corneal astigmatism plus internal astigmatism. Selection of the trial lens based on design and basing of the type of astigmatism. Next, moving on to base curve and diameter and define the power and axis. Insert the trial lens and wait for 15 to 20 minutes for adaptation, lens rotation and final prescription. Here we have the first picture represents the lid tonicity of the patient, where very large eyelid can't be given for the patient. The second is the T-beauty. Next comes the HVID and BVID, and also the palpable fissure height. Selection of contact lenses. Soft lens is based on HVID measurements, HVID plus 2 mm, refraction with vertex distance, and keratometry based on base curve selections, which is 0.3 to 0.9 mm to flatten scale, 1 mm average of K, and 4 diopter flatter change than the average scale. Well, RGB is based on HVID minus 2, refraction with vertex distance, keratometry with base curve selections. A range of BOIZR is required from 7 to approximately 8.40 mm in 0.1 mm steps and 0.5 mm steps between radius of 7.60 to 8 mm. Fit assessment of soft CL is fitting the lenses, settling time, dynamic positions which control position and movements. To look for the soft contact lenses, first we have to see the centration and corneal coverage, which is a limbal coverage, comfort of the patient, stability of the lens, lens lag, and movement of blinking, which includes amount, speed, and direction. Then movement with lateral gaze and push-up test. Based upon the movement, 0.2, 0.4 mm movement is an ideal movement for thin lenses. Then 0.0 mm movement, which is like lesser and greater than for tight lenses, for thin lenses, and lenses and lower than 0.4 mm movement for loose lens, for thin lens. 1 mm to 2 mm movement is an ideal lens for a thick lens. These are the characteristics of each fit, in which ideal fit has comfortable, which is very comfortable. Vision will be crisp, clear even after post blink and pre-blink. Centration and coverage will be central fit, full corneal coverage with around 1 mm limbal overlap. Edge alignment is regular alignment to conjunctiva. Primary gaze movement is 0.2 to 0.4 mm movement. Push-up test, smooth push-up followed by smooth recovery. Loose fits indicates uncomfortable lenses with variable vision worse immediately after post-blink. Poor centration often displaced inferiorly. Lag and sag greater than 0.5 mm. May show standoff or bulking, particularly in high modules materials. Possibly excessive greater than 0.5 mm movement. Easy to push followed by a quick or erratic recover. Tight fit is very uncomfortable lens and none or minimal lens awareness. Variable vision can be there. Full corneal coverage centered in all position of gaze with very little lag or sag. Possibly local limbal or conjunctival hyperemia limbal nipping or conjunctival indentation. None to minimal lesser than 0.1 mm resistance to push with slow recovery. In this, first is the ideal fit, and next comes the tight fit, which doesn't move little bit and has a very tight appearance. And third one represents the loose fit in all gaze, which is primary, lateral, and upward gaze. The first picture represents soft contact lens centration and coverage, which is normal in primary position, showing one limbal overlap. Incomplete second picture shows us about the incomplete coverage, which is not covering the whole of cornea. And the final picture is about the push-up test, how we will perform push-up test. And this push-up test is based on mostly percentage. It differs from practitioner to practitioner. To look for toric fit, again, centration, coverage, comfort, and stability is seen along with lens lag. Movement after blinking, amount, speed, and direction is seen. Movement with lateral gaze is seen. Then push-up test is done along with the rotation, which is the extra only point which is added in the toric fit. These represents the truncation mark, and this varies from branch to branch. This is mainly to see the rotation of the toric lenses. Last, left add and right subtract is then thumb rule, which is used for toric lens. If prescription axis at 180 degree and there is no rotation, then we have to order the same power. Same procedure for prescription axis at 180 and 10 degree right rotation is there. We have right rotation is there, then we have to subtract, which is going to be our 170 degree, which will be the final RX. Same for Same for the prescription, in which if 180 axis is there and 10-degree left rotation is there, we have to add and then we have to give 10-degree. To look for RGB fit, dynamic, centration, coverage, comfort, stability, high riding or low riding, movement after blinking, which is amount, then type, smooth apical rotation or rocky lid attachment, speed and direction is seen, along in which static, central touch, cooling, mid periphery zone, edge width and edge clearance all are seen. This is the first assessment of RGB. In dynamic view, we will see centration, movement of blink and coverage. In fluorescent field, we will see about center, mid periphery, borders and displacement of the lens. Comfort and vision over refraction and moment is seen through the lens. This is the tear lens in RGB, where first one has central tear, then we have a peripheral touch and next one is the central cooling. RGB fit assessment. Fluorescent pattern of a good fit with a minimal apical clearance is seen in the first picture. Second gives us an appearance of a small flat fit. And third picture represents about fluorescent pattern showing as a steep fit. Last one is the against rule astigmatism pattern. This is the picture to understand the steep fit and flat fit. In flat fit, we could see there is a large peripheral pooling, and in steep fit we could see that central pooling is very high. Edge width, the edge width should be very excessive reservoir. It is an unstable fit. If it is inadequate reservoir and if it is a narrow edge, it is said to be the stable fit. And these are the lens in which uppercase and lowercase are seen. Ideal fit in a case of keratoconus, the first picture represents the correct 3-point touch of the keratoconus. The second picture represents lens and presiding on the cornea, and it can induce scarring, excessive clearance from the cornea causing discomfort. And thank you so much.
Thank you so much, Deepika. You can unshare your screen now. I also request the moderator to add your opinions on it, sir.
Deepika, it was kind of a very good talk. Before I start, I would just like to take the opportunity for Agarwal Eye Institute for having me, and thank you. I wanted to thank Anshika, Gomati, and Meenakshi, for arranging and conducting the whole session. Before I put my technical comment on this particular talk, I would like to congratulate the whole team for taking this kind of initiative where students takes the initiative to present her talk, and then they're exposed to online and to the other audience, and which goes into YouTube. I think it's a great move. I'm just taking a note of this. I kind of like the whole thing. So this is the first time I'm setting this kind of session where an institute is actually going live in YouTube and keeping it for the student and opening to the wide audience. So first on my note, many congratulations to whole team and taking this initiative.
Thank you so much, sir. This means a lot to us.
Okay, now coming to this topic, so right now, shall I just give a brief about the talk and probably my take on this? Is that you want?
Yes, sir, please.
Yeah. So those who are listening to me, probably the students and probably Deepika, it's a very vast topic that she chose, fitting of soft toric and RGP. Here, as a practitioner, as an educator, I want all the young optoms to understand why you wanted to fit contact lens. So this is just another mode of correction, right? It's an alternate mode of correction to spectacles or refractive surgery. Now, we fit contact lens, and there are many types of contact lens. Right now, we spoke about soft and then soft toric or this RGP. And then again, material wise, it get further divided into many. It is very, very obvious that we need to understand whom to fit contact lens. So often, I have been taught when my teachers were asking us, whom you think that you should recommend contact lens. And then students typically ask those who have high power, those who have anisometropia, amblyopia. I mean, first thing first, to student understand this contact lens can be for everyone until otherwise it is contraindicated. I mean, this is the point students should understand. This is alternate to refractive error management. It's another mode of refractive error management. Like how you prescribe spectacle, you can prescribe contact lenses. Until otherwise, it is contraindicated, which is very rare. So contact lenses for all, right? You can manage a minimum refractive error, a high refractive error, a cylindrical correction, or in that case, presbyopia, multifocal contact lenses. I am leaving all the other indications where therapeutically and optically we indicated, like let's say irregular cornea, where someone has an irregular astigmatism, you try to correct with advanced RGP lenses. You wanted to use that scleral lenses. So they are basically, indicated optically because other means cannot correct it. Just for an example to the students, if someone has keratoconus, your spectacle may not correct the refractive error. So what happens, you choose a good RGP lens to cover the cornea and let the tear lens do the magic and correct the irregular astigmatism. And then from there you go advanced RGP design, Rose K and other brands of contact lenses. And if it really goes, the ectasia goes very far, or any other cases, let's say post-refractive surgery, post-PK traumatic cases, where I choose the scleral lenses. So those are optically indicated, or in that case, a bandage contact lenses, or to protect the cornea, you are giving ocular surface disorder scleral lenses. So anything which is optically and therapeutically indicated, you don't have any other choice to fit contact lens. But then a regular contact lens for a soft toric or RGP is indicated someone who has refractive error. You just need to understand the nature of refractive error. So that is the first case of choosing contact lens. And the second point is what kind of contact lens that you fit, right? So you have option of soft toric and RGP. In soft, you have usually, let's say, hydrogel lenses and silicone hydrogel lenses. And then again, you have, they are yearly disposable, some are monthly disposable, some are one-day disposable. So again, these all are catered to the need. I mean, you see in the road, especially for the students, I'm saying there are many vehicles, but then it catered to our needs. Right? So similarly, these contact lenses are there to cater to our need. So you talk to the patient, you explain. So I always say to my student, okay, what you do is you explain, you listen to them, you explain, and probably help them to come to the conclusions to decide what lens that they come. Now, few of the cases, if someone has got a corneal astigmatism, right? Now, RGP lens, the tear lens, as Deepika says, would be a great choice to correct these corneal astigmatism. But again, when examiner asks in exam whom to fit RGP, so student often say high refractive error. I mean, for high refractive error, yes, you can use. There is no doubt about it. But then you can even correct a low refractive error with RGP. It's just that, you need to explain them the benefit of RGP. So the key point for RGP, I would just come with one lens. It has got a fantastic physiology because this lens fits 60 to 70% parts of your cornea and it moves. So it gives a better tear exchange. The decay of a RGP in modern RGPs, we start around 60 to 80. Now we go in India, 90 decay, 100 decay. So they are very high oxygen permeable lenses. So they are very good and physiologically inert. That is what RGP does to eye. Now you have a spherical contact lens and you have a toric contact lenses. I'm coming to the soft lenses. Now, if a cylindrical amount is 0.5 to 0.7. I mean, you can manage with the spherical lenses, but nowadays, we meet to the company, our company counterparts, their representative. So 0.75, if you try to manage with the spherical equivalent, visual acuity and contrast drops. So better you can start thinking about soft toric from, if anyone has a refractive error, along with a spherical component or even particularly a cylindrical component, 0.75 and above. Otherwise, soft lenses will do the work. Now, though we have yearly disposables, monthly disposables, I mean, it is advisable as a contact lens practitioner, you don't go yearly lenses because you use these lenses for a long time. So what happens, these lenses, pick up this deposit, and then it acts under your lid and then cause some of the allergic responses. So it is always advisable and better at least to use a disposable lenses. One of the very good practice that, you introduce monthly disposable, a hydrogel monthly disposable. Now, if you can educate and explain these patients, probably the benefit of that, then you can even upgrade them into bi-weekly or a daily disposable lenses. Someone who has a long working hour, who comes in office at 8 o'clock, goes at night 8 o'clock, or remove the lenses by 9 or 10. So that means average wearing time is 12 to 14 hours, works in air condition, so those are the cases. And if you examine and see there are hypoxic changes at the end of the day, or patient is not comfortable, a silicone hydrogel is the choice. Now, again, just because they're high cost, that not necessarily they are always better. Okay, please understand, silicone hydrogel lenses, the modulus, that means the flexibilities, are little more than a hydrogel lenses. So initially, patient may feel that something is there in the eyes, right? Having said that, in present generation, the silicone hydrogel lenses have got a very low modulus of elasticity. So silicone hydrogel lens can do the wonder. Soft toric, okay, it is, suppose someone has got an internal astigmatism, there is no corneal astigmatism. Soft toric is the answer because there is no corneal astigmatism, so that a RGP lens will do the work. So in that case, a soft toric will do the wonder. I was going through the presentation and Deepika, she was showing some of the marking of that. Probably you can refer to the company produce marking. Not all the lenses are prism ballast. There are many other design. Every company they follow. So once you go to their product, you can see which design. Like Bosch and Lomb predominantly uses the prism ballast design. There are other designs are used by other players, present in the market. That is the one thing. And if you just do the soft toric, very rare cases you will see the lens rotation. That means after blink, the marking where you want, they may not settle in the same position. A very rare cases, they may be, a little away from their required position. And those things, what you do, you basically compensate the lens rotation. You don't correct. The word is a compensate. You take advantage of the rotation and you correct by applying Lard's rule or even CAS rule. So Lard's rule, whatever says left add, right subtract, whereas CAS says, clockwise add and anti-clockwise subtract. So these are the things you can do. Few of the success story, if you see the refractive error, if your spherical component is higher than the cylinder, typical example, -4 with -1, 1.25. This is a very good way of correcting soft toric. If sphere and cylinder is half, -4 with -2, that also gives a correction. As the spherical comes down and cylinder goes up, and from there only a minute movement can cause problem. Those cases, a little steeper fit, a less rotation will give you a good vision, probably post blink. I mean, these all things in a nutshell, if I just say, no, you need to think, and I will be, looking forward to see if anyone has some questions and if I can address them. Over to you, Meenakshi.
Thank you so much, sir. It was an elaborative explanation of what to choose and when to choose. The students might have understood whom to go for which type of contact lens. So from the student's perspective, we have a few questions on Zoom platform, sir. What is the main point to see for the CL fit assessment in case of RGP and soft?
The main point that, it ensures, fitting ensures the comfort of this. When Deepika was presenting, like there are many analog score you use, neutral, worst, bad or worst, good and best. So I always say don't use anything in negative point. Otherwise it registers in patient's mind that something can go, negative. So I usually use it, one of the literature I found 0 to 10. I said 0 is not very comfortable, 10 is very comfortable, and 7 is something you want. I always teach students in that way. So it helps us to understand whether this lens and then what I try next is actually improved over it or not. So fit assessment is the first thing, is it ensures the comfort. It also ensures the safety. I mean, one of the slide, Deepika, where she said, if the lens is fitting too tight, there may be indentation marks, especially for RGP, and soft lenses, it will do around the limbus, which may be a potential risk for later in case. So actually safety and comfort is addressed by fit assessment.
Thank you so much, sir. Next, and conventional question for in case of soft contact lenses. We measure K before the fit assessment, right, sir? But we go for universal base curve. So which is better for the patient? Universal base curve does a good job when compared to the conventional method of assessing keratometers and producing a base curve?
I'm very glad to see this question. Many congratulations whoever asked that question, and actually that shows that you have thought about it. So a very great question. Please understand, when you learn about fitting, how fit should be done. That means, if your corneal readings are, let's say, K readings are 42 and 44, or in that case, if I just tell millimeter, so that you understand, let's say 7.5 and 8. Or 7.5 and 7. Now, what it says is you add 0.8 to 1. That is the reading. So 1 you add to the average K and you get it around 8.5, 8.6. Now, this company, they have used, all these normative parameters. Like how you don't go and ask your feet size and say, give me these shoes. The company has already got the fit size, in the normal parameter. And then they made 42, 40, 38 and different kind of size, which comes in different European parameter and British parameter. Similarly, for the shirt sizes, XL, double XLs and all. Please understand this contact lens is considered to be FMCG. That means first moving consumer good. And it is like you can buy from a counter and then you can use it. In order to make this ready-made lenses, they need to have the parameter. So right now, this you get over the counter. But then this knowledge of yours, first it will help you in case if you go to a lab and wanted to order. There are lab in India, probably for, just to keep the interest and other, I'm not naming those lab. You can even order your customized soft lenses. You can order. So that if you want a particular base curve and diameter, they would make. But then when you go to the multinational company, all the company which is operates in India, they have ready-made lenses. So which gives a different kind of an unifit. So earlier when I was student, one of the company was giving 8.3, 8.5 and 8.9. Now they give all in around 8.5 or 8.6. So what happens is, you have this parameter, but if a fitting, so those things will fit in 90% cases. If it doesn't fit well, it will help you to understand by doing this trial, which brand will go. So how it goes is in the same company in the profile. If I take, let's say, Boston Law, they have one of the hydrogel, one of the silicon hydrogel, and there are many lenses in their profile, similar for Johnson & Johnson, Cooper, and Alcon. Now, what happens is if one lens fit little tighter, the next lenses will be little difference. Maybe the thickness may change, the total diameter may change, the base curve may change. So what happens is you will have understanding, if I move from this lens, probably that lens will give me a better fit. So that is why it is for your learning. But as you said, you get a ready-made lenses, but then to understand if the fit is not good and bad, you must have the K readings.
Thank you so much, sir. The next question will be, is it necessary to use fluorescent for RGP static fit assessment?
Yes, it is necessary because your tear do not have any color, right? Your tear do not have any color. So when you use fluorescent, the tear takes up, the source against the blue light. It appears as a green. That is why you use a Ratten filter to get a better view. So what happens in order to do the static fit? Static means when eyes are not blinking. You see the lens cornea relation by observing the tear. So tear is there between lens and cornea. Now lens is transparent, your cornea is transparent. Now you do not know what is happening between lens and cornea, between the lens and cornea. What is present? Tear. Now what you become very intelligent, you just touch a little fluorescent there. Now the tear got a color now. Now you understand if tear is present or absent there. It helps you to understand the fitting, especially static fit for RGP contact lenses.
Thank you so much, sir. Next, again, from the student's perspective, what to do if the fit is steep? What to do if the fit is flat? How should we proceed with the management of attaining an ideal fit?
Yeah. So when you do the fit assessment, first you find out why it is steep. Is it the total dia is making the play, or it is the base curve? So your fit evaluation will reveal you. Let's, for an example, use an RGP lenses, which is, let's say, 10.5, which is very high dia. And you saw the lens is fitting too tight, and you saw the coverage is too much. And this all the lens edge is touching the lid. So what happened? It is very obvious you play with the total dia. You reduce the dia in order to improve the fit. So it is your assessment will tell to increase the dia or decrease the dia. First you assess the fit, whether it is steep or flat. If it is steep, now you know that you need to reduce the dia in order to get a better fit. So you can play with the base curve, you can play with the total dia, but first you need to assess and find out what is playing behind the curvature. If the coverage is good and lens is fitting steep, you just flatten the base curve.
Thank you, sir. And in case of soft lens, we are going with a universal base coverage. In that case, what can be done for the change of fit assessments?
What can be done for the?
A change to bring it up in an ideal format.
Yes. So suppose a uniform base curve or so what happens is a company may offer a particular one base curve or may offer 2 or 3 base curve. In modern scenario, by practicing different brands, I understand most of the company offer in their portfolio one base curve. Some of the company does it two. Now I rarely someone does 3. Now what happens if that doesn't fit? As I said, so same company will have other lenses in their profile. Like you go to the car company, you have hatchback, you have sedan, you have SUV, micro SUV, big and big. So when you are a student, you buy a hatchback, and when you become a very successful optometrist, you look for a very posh car. The same company will upgrade you from this. So this also in the same way, when you do not get a proper fit with particular lenses, okay, that's fine. You try to see in the same company other thing. If not, you go to the other company and look for the other parameter. So first you assess the fit and find what led this fit, not a good fit. And then see the other parameter, otherwise you go to the next company.
So much, sir. And clinically, how good the RGP fit is? Is the patient accepting the RGP lenses, sir?
Sorry, say it again. Yes, say it again.
Am I audible?
Yeah, you are audible, Meenakshi.
So clinically, are the patients accepting RGP lenses? So what is their idea about using the RGP lenses, sir?
How their idea about?
Using up the RGP lenses.
I'm just trying to understand the question. They are saying how patients are using RGP lenses or how we
Are they accepting RGP lenses?
Yes, it is. They can. It depends. It depends. So I always say RGP lenses are. To be very frank, as a contact lens practitioner, I say RGP lenses are safest. It is like something which is like exercise. I mean, initially you may not like, but long term it is good for your health, because RGP lenses has got 2 very different and good advantage. One is their decay value is quite high, and second thing is there is a very great tear exchange. Now these 2 things keep the lens physiologically inert for long term. So even if you see long-term changes, you very rarely can make out, this patient who are using an RGP. That's the benefit. And now we get a very high decay, 100, 120 material of RGP lenses, which are flexible as well. They are comfortable and they have a very great wettability, and you can use it. So this only thing is what during counseling. So that's why when you present your lens to the patient, what you do, you listen first. What is their requirement, why they want contact lens, and you explain your different types of contact lens to them. And if you feel they have astigmatism, especially it is corneal astigmatism, you explain the advantage of RGP, and then you tell that initial difficulties or the adaptation time for a RGP. And probably once you explain everything and you say that over the period of time they're gonna get comfortable, and you will see this, you can do the miracle.
Thank you so much, sir. And we are done with the Q&A session as of now. Ma'am, are you there? Hello. Ma'am, do you have any questions for sir, ma'am?
Yeah, did you call me only? I'm sorry, there's too much of noise around me.
Yeah, ma'am.
So, okay, yeah, Meenakshi, thank you, Premjit, for such a detailed explanation. So, I'll just try to summarize what he's taught us today. That first of all, CL is for everyone. So, we should understand that we should not stop anyone from wearing contact lenses, or we cannot decide that he's the person or she's the person who can wear contact lenses. Second, understand the nature of refractive error for which we want to make them wear contact lenses. And third, then we decide what is the type of CL and then look for the fit. What is most important after fit assessment is counseling. For a patient to really be happy with the contact lens is how we counsel the patient and how we are looking at the fit. So those are the two things which will really make us happy as well as the patient happy. So thank you, Premjit and Deepika, for such a detailed insight into CL and its fit and the types of CL. So thank you so much for giving your time. Over to you, Meenakshi.
Thank you so much, ma'am. Thank you so much, sir. We are really excited to value the excitement you showed us in teaching the concepts to the students is very. We are so impressed about it, sir. Requesting Gomati to take over the session right now.
Yes, thank you so much, Meenakshi. Premjit, sir, that was excellent. So thank you so much for joining us today amidst your busy schedule, and thank you for patiently answering all the questions. So before thanking Premjit sir, I think it's my duty to thank Anshika ma'am for roping in Premjit sir today. Thank you so much, ma'am.
Thank you everyone for having me, and I really enjoyed the whole session. And by doing this, I would also can meet my old friend Anshika, and then probably to get to know Meenakshi and you. And you guys are doing fantastic work, and I really like the whole concept.
Thank you, sir. So I'd like to host you on another wonderful platform, sir. Thank you so much.
Definitely, thank you.
So dear audiences, thank you all so much for your continuous support. If you have any questions regarding today's session, please post your questions in the comment box. We'll get back to you with the answers. And we have an announcement today. I request Meenakshi to share the invite of the upcoming dispensing workshop. So audiences, so here is the invite for the dispensing workshop that is happening on April 28, 9:30 a.m. to 4:30 p.m. The best thing about this particular workshop is it is completely an interactive session, and it is limited to the first 100 participants. So please enroll yourself. The link to this particular workshop will be given in the description box. So thank you all so much. If you like this video, give a thumbs up and share with all your friends. We'll meet you in the next episode. Thank you.
Thank you.
Thank you, sir.
Thank you so much, everyone. Thank you so much, Premjit. Bye.
Thank you, ma'am. Bye, ma'am. Bye.